Hi everyone, and welcome to episode 10 of The Only Ways Ethics. And we have with us Tom Bradshaw, who is a clinical safety officer and a GP in the Leeds area. Welcome, Tom, and thank you ever so much for taking the time to do an episode with us.
No problem. Hi, Dean.
So, Tom, we're gonna crack on. I think by now, and welcome to the audience as well, to everyone who's watching and listening. I think everyone knows the format by now with the only way is ethics. So we'll crack on. If you could sort of tell us a bit about yourself. And what you do and your journey into digital health, and then we've got some interesting topics to discuss as well. So I'll hand over to you.
Yes, of course. Well, thanks for having me on, and delighted to bring up the big episode 10 as well. It's good to get on and be able to talk to you. I think a bit about me. So I'm a GP by background. I've been a doctor now for 10 years, and obviously been involved in health and social care for about another 10 years previous to that, in training and volunteer work. But kind of most relevant to this podcast and to the work I'm doing now is that I'm a freelance and independent CSO, doing some work through my own company and also through yourself, Dean, and DPM. And I suppose the journey I've taken is a bit by chance, as a lot of people have, and a bit by design. But it's really to try and get myself with a bit of kind of a better work-life balance and a bit of a better enjoyment of the work I'm doing. I think we've discussed before about the stresses and strains of being a sole GP just working full-time clinical work, and it was whilst doing that I made the decision to kind of change from purely GP work to look to doing something a bit more strategic, using a different bit of my brain, that wasn't just dealing with 10-minute silos of problems that you can't always, well, very rarely solve in 10 minutes, and quite often leaves you quite frustrated. And it wasn't really suiting who I was and where I wanted to be. And decided to make the change about 18 months, 2 years ago, which was a bit of a leap into the unknown. And my last day working as a full-time salaried GP was the day my wife went into labour. So not only was I going to be unemployed, but I was also going to become a dad for the first time. So that's a day I'll never forget. And but since then, I've met great people like you, and really enjoyed the journey, and it's definitely been the right decision.
No, that's great, and thank you for that, Tom. So it sort of that full-time role as a GP, and I think in that role as well, Tom, you must have been exposed to a lot of sort of digital health within there. If we just sort of, I will come on to sort of like talking about primary care and clinical risk management, but just want to get your sort of like, so you're a GP, working in primary care. You said you have these 10-15 minute sort of like slots where your goal is to try and sort of create a plan potentially for a patient, know what's wrong with them, and send them out feeling confident that they sort of they can go forward and sort of and become better, or so.
Or at least not get worse. Hopefully,
or at least not. Yeah, absolutely. Or at least not get worse in relation to that. But where does digital health come into that in your respect, and what have you seen over the 10 years in relation to the sort of like the uptake of digital health, and how does it help you in your role?
Yeah, it's a good question. I think digital health in primary care is pretty much ubiquitous now. So it's been there. I was doing a bit of research, and I think some of the practices that I locum through and work around in Harrogate and Leeds, they started their digital transformation in the early 90s, mid 90s. So you're talking about a process and technology which has been fairly well established when you're comparing it to secondary care.
Yes.
And that's has two effects. And number one is that people are generally quite comfortable with using the two major EHR platforms that are there, and are fairly confident in their outputs and confident using that relatively speedy to doing their consultation. But it also has the opposite effect, that it can mean that I think the pace of change and the pace of development and innovation within primary care has slowed. And I think what was initially probably a revolution back in the early to mid 90s, stretching into the turn of the century, has now turned into a slow evolution, and potentially even a slight stagnation at times. I think looking back, the biggest change I've seen was around the pandemic, when we had a lot of new technologies come in, because we obviously had to do video consultation and messaging, and that really kind of accelerated changes which needed to happen, I think. And you look at kind of things like the shared care records, that link up between primary and secondary care, which is coming in, and I think that's crucial and really overdue, because we're not operating in silos. And one of the issues with being a GP is that it's quite a lonely job. You can be in your office, 12 hours a day. You obviously see loads of patients, but you don't actually really often get to talk to colleagues and friends that much, because you're just always, working flat out. And I think the frustration from my point of view was that when you look at other industries, so look at banking, for example. When I qualified as a doctor, if someone said you'd be able to do your banking on your app, and you would hardly ever go into a banking, an actual physical bank, and you'd have online banking, but actually people don't really use that. They only really use that to reset their password for their mobile, to be honest. So you look at the rate of change in an industry like that, and then compare it to primary care, and yes, things have evolved, but we're still doing the same kind of processes and the same working in the same way with pretty much the same technology. And it was frustrating for me. And I'm not afraid to admit that during the back end of my kind of time as a regular salary GP, I was struggling with burnout. I was struggling with the attrition of primary care, and I had a bit of kind of I won't say a crisis of confidence, maybe a midlife crisis is the kind of the better way of putting it. I'd always imagined becoming a GP partner and being able to make a change within the practice that I was at, or the locality I was at. And I realised that even at partnership level, that change, they're operating with at least one hand tied behind their backs at times. And it was, actually I had a bang to my head playing squash, and I got concussion. And I think that was a moment when I realised that actually I needed to change. I kind of woke up the next day with concussion, and slowly realised that actually I didn't want to be a regular GP anymore. And that was the moment. But yeah.
So a moment of clarity there. We were sort of having a knock on the head.
The squash racket,
making that decision.
Yeah.
So it's interesting, Tom. You talking about sort of like burnout, primary care, the whole piece around digital health has been in primary care for a long time, and I think we tend to forget that you're absolutely right. I mean, those EPRs, EHRs, whatever we want to call them, and and I don't mind naming names. We know who they are. Everybody does EMIS and TPP within those within most GP practices. So you would expect that being the case, that I'm going to come on to the big sort of like whether it's an elephant in a room or whether it's sort of like it is an issue, is that there seems to be this knowledge gap in relation to clinical risk management from secondary care to primary care. And the reason I do it that way round is because I think from my experience in the past 18 years, secondary care seem to apply the clinical risk management process a lot better than primary care. And this seems to always be the case. And it would be really good to get now you've ventured into sort of like that sort of like the clinical risk management arena. And it'd be good to get whether you agree sort of like with that, and if so, why do you think this is the case? Because you're first hand there sort of as a GP and exposed to that, and so it'd be good to get your
I think that's I agree. Number one is that I agree, and I think a lot of it comes down to education, as I know it's something you've discussed many times. Listening to your podcasts and talking to you previously, education is a big thing, raising awareness.
Yeah.
When I graduated from medical school, when I completed my GP training, if someone had said clinical risk management, if that came up in my end of GP exam, define clinical risk management, I'd probably just put a question mark and put something about, keeping patients safe and move on to the next one. It's kind of like, it just wasn't covered, and let alone the DCB standards. So you then it's then moving through to actually it's only when you actually take an interest in the field and an interest in digital health and health transformation and patient safety that you start to realize and understand this is actually a thing. This is actually a field. There are actually experts in this, and this is also something which health organizations, GP practices should be having within their organization, or at least within their locality. And there it goes back. There's a couple of things to remember with primary care, which I'll recap for the audience, and apologies if it is a bit basic, but it's worth remembering that primary care compared to secondary care, GP practices are private businesses. So these are private partnerships owned by a group of partners, normally GP partners, and they have pretty much complete autonomy over where they would like to go within their business. So they can decide, as long as they keep within the terms of their NHS contract and their contract with the ICB, and they can decide to take the practice in whichever way they want, and they can obviously develop and incorporate new technologies along that route if they think it will serve their patient population better. And it's one of the beauties of primary care, because you can then innovate and tailor your services to the needs of the area you're providing. But it then creates challenges, because if you're trying to diversify, you have to also stick to the governance processes, and you have to be aware of the governance processes. And if you're not aware of clinical risk management, then you don't have a hope of completing them, do you? If you don't even know, if it's an unknown, then it's not even on your radar. And of course, there's levels above that. So there's primary care networks, which are groups of similar GP practices, normally based in the same location with same patient demographics, who can quite often bring technologies in. And then above that, there's the integrated care boards and the ICBs who can bring technologies on into a practice level across hundreds of practices, and that's very regional, as we know. So, and you would hope at that level there's CSO input, there's clinical risk management input, but certainly the lower down you go because of a lack of awareness, and also a kind of so many demands on practice partners. They're fighting fires left, right, and centre. They are looking for something which can help make their practice more efficient. The last thing they want is to then be loaded with a whole pile of regulations that they've not even known about, and that they don't even they're not even prepared or don't have the expertise to complete. And certainly if you've already completed most of your digital transformation journey, with having System 1 or EMIS in place, and then you've not had to consider the regulations, the DCB regulations for, well, possibly forever previously.
That's really interesting, and when you look at that sort of the whole hierarchy in relation to GP practices. So, in the first instance, and it's really interesting listening to you talk about that, Tom, in the first instance, talking about the autonomy of GPs. Then when you talk about the PCNs, and then that autonomy is slightly skewed. And then when we go to ICS and ICB, and as we both know, from doing sort of like clinical risk management work and working with some of these entities, that sort of there is decision making at that point as well, to say these technologies are coming in and they will be procured across the whole sort of like region. So therefore, where is the autonomy within digital health? Because if a GP surgery says, I don't like my incumbent EHR, whatever it is, and I want to change, and that's then made very difficult, isn't it? If the rest of the region or your PCN, etc., and stuff like that, and you're getting pushback, and if it's for the greater good of the patient, and it's going to make your practice, your surgery more efficient in the delivery of care management, all of a sudden that becomes very difficult, doesn't it? As if you're almost like a lone wolf, aren't you? Sort of like out there trying to bang the drum and promote this. And I think you're absolutely right. I don't think there's any at the moment. It's trying to find the answers around how do GP practices manage clinical risk management in relation to, is it possible for all practices to have a CSO? I would say, or do I dare say yes in relation to that?
Go on, step off the fence, Steve, and commit.
From where we are, no, absolutely. I always step off the fence, Tom. I don't sit on it at all. And yeah, why not? Why can't you train? Why couldn't you possibly train at least train someone within clinical risk management to a particular level?
And I think it's the difficulty is that when if you're doing it as a CSO from an ICB level, you don't have a chance of understanding the different workflows if you're completing the 160 for the hundreds of practices within your ICB. It's impossible. So actually, is the 160 you're producing complete? No. Is it that relevant to the and practice if it's not considering their bespoke workflows? It's not going to be, is it? It can only it can address some of the hazards, some of the risks, some of the controls, but it's not going to address all of them, because you're not going to be aware of them, and you can't at any point become aware of every practice's workflow. It would turn me grey probably.
No, you're absolutely right, and there needs to be a structure in place, and there needs to be a deployment model, doesn't there, in relation to that? Something that we've sort of like we've supported within sort of like our organisations, and you're absolutely right. If there's an expectation for an ICB and ICS, we're not saying that the work cannot be supported at that level, and that there needs to be work completed.
Yeah,
However, that needs to cascade down to the
exactly.
PCNs, to the surgeries, and then needs to be, the important thing is, and this is for, again, for the audience out there and everyone listening, there needs to be input from those people. And if you're going to get input from the surgeries themselves and from PCNs, then again, there needs to be awareness raising,
Yeah,
which it brings it back. And I know it's sort of chicken and egg in relation to that, but it needs to happen. And I think that the sooner that we raise the awareness and make people aware that, um, this this does involve you, like, Kimberly Dawson said on her sort of like talk. I'm going back to sort of like, Rewired in back in March, and the talk that she did about, it's everybody's responsibility.
yeah,
It's not just one person's responsibility, it's everybody's responsibility. Everybody should know in relation, because digital health is not going away.
no, no,
It's here to stay, and it is now. It is a huge part of our role, not just as clinicians, but administrators, everybody that works and touches sort of like, touch point with the patient, in whatever way, shape, or form that is. Whether that's booking appointments, referrals, anything in that administrative, and then on to sort of like, the clinical management of the patient.
yeah.
We all have a responsibility, and we need to sort of like, move that forward. So you that journey then, Tom, from from GP,
Mm,
fully paid in GP with all the issues that come with it, but also all the sort of like the enjoyment as well, because you don't just sort of like go into this, do you, sort of like blind. You
yeah.
know what's there, and then
And
you make the decision and you take the steps to become a clinical safety officer. And but with that, venturing into the independent sector as well,
mm,
which is no mean feat. I think we, some of us have, I know I did it, from nursing into independent sector. Bit of a different route for me, joining a EPR supplier and then becoming a CSO. But you take that sort of like that step, and you're supporting digital health projects. Um, so it'd be interesting to how's that, if any, has that changed your perspective of the NHS and the approach, the approach to digital transformation, as opposed to, from GP, and then in comparison being a clinical safety officer. How's that changed you in that respect?
I think number one, it's made me more aware of the systems I'm using. So I now look at the systems I'm using and think, um, and you start noticing some of the hazards that you might want to put in a hazard log when you're using them, which is which can sometimes make you a bit more wary. I think from looking at the the path from developer and the private sector moving into the public sector, I certainly had a very when I was sat, in the public sector, I had a very rosy view of private sector. Thought it would be very a lot more efficient and um, uh, how can I put it, more responsive than primary than public sector. And I think there's different challenges between the two, really. I think the private sector. Um, One thing I've been surprised about looking at it is the number of times that um, health technologies have been developed and are close to going live or have gone live without the clinical risk management process having been completed, without the without the DCB 0129 in place, without DTAC completed. And you think, well, how has it got to this stage that you haven't formally considered this? And I think some of it is a lack of awareness from their point of view. It's really worrying when you know that it's live and then you do the workshop and you find things that are wrong with it and patient safety hazards. And you're then in the very tricky position of trying to work out, is this, is it, what is the relative risk of terminating or this functionality whilst you try and correct it versus the harm that might do to the workflow of the organizations that is using it. And then you're really stuck between a rock and a hard place. And I think idealistically I had in my head when I was moving from public to private sector that they would have their ducks more in a row, if you know what I mean, and have be more aware of these standards, because they want to kind of expedite the selling process and make sure they can get deployed as quickly as possible once they agree a sale, and also to protect themselves from any reputational damage and reputational risk that comes alongside a health tech solution that hasn't been checked for patient safety hazards. And that's not always the case, which was surprising, really. And I think it goes back to the kind of the carrot and the stick about how you can encourage and incentivize developers in the private sector to use and to adhere to the DCB standards, because I think the private sector can be more responsive, certainly to market economics than the public sector, and that maybe is an opportunity within that. But the message I'm always trying to deliver is, whenever I'm now working with private sector developers, is that it's striking the balance between innovation and implementation, and that that's my key headline really, is that as much time should be spent on the innovation on the product and also on the implementation of it, and that if you don't give as much time, consideration, effort, and money on both processes, then you're setting yourself up for failure. You're setting your product up for failure, and you're introducing harm to the patient, and you're going to introduce inefficiencies to the NHS staff, which is going to make them very dispirited and disengaged with health tech in general, really. So I think it's I think there's an incentive from the private sector to really consider this as a way of building up their profile, and also making sure that their technology is as safe but also as efficient as it can be for the end users.
No, thanks for that, Tom. And it takes me back to, interestingly, if you look at industry, which you focused on there, and sort of like the manufacturer side, and that sort of almost that realization, isn't it, that and I think I had the same, but from a different perspective when joining sort of like an EPR supplier, and you think, oh, they've got all this money, and they've got all this staff, and they've got resources to chuck at like everything, and quite quickly you realise that it's no different than the public sector, because you're dealing with egos, attitudes, and little pockets where there's lack of knowledge, etc. And sometimes not everyone pulling in the same direction, and you still have to deal with that, and you have to manage that. But I think importantly, and one of the things that I think we really need to sort of like try and drive home in relation to clinical risk management is, and I know I keep going on about raising awareness, but it is all about this. You don't know what you don't know in relation to that. But key to that is top management. If you look at section 2 in both the standards, DCB 129 and 160, there is a level of responsibility from top management to make sure that the right people are in place, the right process, and that they are aware. Because 9 times out of 10, when you go into an organisation, if top management aren't aware of these processes and they're not really sort of receptive to those, it's a lot harder job then to try, and it's a bit of an uphill struggle to try and sort of like push this forward and get these processes in place.
Exactly. And And I was listening to, sorry to interrupt you,
No, no.
I was listening to your previous podcast with Adrian, and he was saying pretty much the same, wasn't he? And saying that actually when you, hopefully when these standards are revised, there should be a lot more emphasis on top management and a lot more emphasis on the responsibility that they have to ensure that it's not just, like you said, the standards at the moment are quite wishy-washy. They're quite vague. What's it, making sure that you've got, enough resource available, and that there's enough consideration and time for it, and that you have a CSO. It's not setting out their responsibilities, their that they are the ones with the overall responsibility for the product, and that they need to that their processes should reflect that. And the analogy I try and give to companies when I always try and bring this back to kind of having a car. And if you can spend as much money as you want on buying the flashiest classic sports car that you want, but if you want to take it down to the track to race, you still need to have made sure that A, you know how to drive it, B, you've got your MOT, it's been serviced, you've checked its tires and its oil. If you haven't done those basic things, then not only is that driving your car not going to be a very pleasant experience, but it's going to be potentially unsafe and hazardous. And the responsibility for that sits with everyone. It should also sit with the top management, who are responsible for the processes of the whole business and developing it. And I think sometimes, and this is probably true in a lot of industries, we get too caught up in the glitz and glamour of what it is we're trying to develop. So we get caught up on the exciting AI features that this innovation may have. And I mean, Het was great. We're both there. So lots of great AI products and great technologies being developed. But the incentive and the appetite to develop great innovative products without considering actually what is the workflow that's already in place, and actually what is the question that I'm trying to answer, and what is the problem I'm trying to solve, and not just how can I make this look as marketable and as exciting as possible is really important. Because there's no point developing a really great innovative product if once it goes into a GP surgery or a hospital or social care, it's not really that useful. And I think that's something that as a GP and a clinical safety officer, I always feel like I'm advocating on behalf of patients, because we're all patients, but also advocating on behalf of my fellow clinicians and staff members who actually have to use these products, and to say, is this going to be useful in the setting you want it to be in? And if that's a no or a maybe, what can we do to make it more user friendly and accessible? Because I think that's the crux of what it is, and that is actually what makes a health tech solution useful and impactful on the NHS. It's not all about all the great features that you have, and all the fancy AI features and stuff. That's great to have, but it's how it actually ties in to the bigger picture, which is really important.
And I think we're in a privileged position as well, Tom. I think as CSOs, because one thing that I've found is that as we progress on our journeys and on our careers as clinical safety officers, you do start to gain exposure and knowledge of multiple digital health technologies and systems. We are, under the bonnet, actually looking at the nitty-gritty and those functions, those features,
Yeah.
the related hazards, etc. So, we're in a position to be able to advise and guide in relation to that. Whether that's listened to or not is one thing that I always struggle with sometimes, and can get quite despondent in relation to sort of the manufacturer's, attitudes, not just from the manufacturer, but from health organisations as well.
Yeah.
But it's great, and it's really interesting. You're talking about sort of, it's not all about functions and features. It's about the need, isn't it? And especially when we're talking about AI, what's the need? There's a big push at the moment about sort of, AI and sort of like, oh, we have to have that in our health organisation. And it's like, well, hang on, take a step back. Why do you need to have that in your organisation? What is it? What is the need? And what are you actually supporting in relation to that in the delivery of care management? Um, and
And I,
and in your role as a clinical safety officer, you've come into this new, this new arena of clinical risk management. You get trained, and it would be good to get your perspective in relation to, and I know I've been sort of like a part of that journey in relation to you sort of like, coming on as a CSO. I'm a big believer in the adoption of the clinical risk management process, and as part of that, giving people the opportunity to be mentored. You've heard me on previous episodes as well saying that, clinical safety officers, you don't just do a day or 2 days training and then all of a sudden there you go, there's a pretty certificate, and off you go and start creating merry hell with systems, because therein lies the risk. And it's all about sort of, making sure that it's structured in the approach, and that you have the necessary support. And I think the reason I ask this question is for sort of, getting your perspective of how you found that approach and mentorship in general, and a message really for the audience to sort of like, to take this on and really think about what you're doing when you're training CSOs. It's not all about just getting the numbers up, which I find. It's about training people and then saying, okay, well, where do we go next?
Yeah, well, it's about quality over quantity, I think, really, isn't it? I think it's what you're trying to say. So, full disclosure to the audience, Dean is my mentor, and he's been mentoring me over the last year. So I have to say, I think the mentorship is brilliant, and Dean's been a great mentor. I think he would probably cut me off his podcast if I didn't say that. But joking aside, the mentorship program is invaluable, and I think it's really important to find a good mentor as well. And I'm sure we'll talk a bit about some of the programs I've been involved in previously, but one of them, the Bike Labs Fellowship, which I did in the spring. There was quite a lot of people, aspiring CSOs, let's put it that way, on the course, and they would come to me and say, what's your top tip, Tom, about how can, I've done my NHS training, I want to go, how can I get clients? And I said, well, take a step back and think about, actually, are you ready to go? It's more than just having done a couple of days of learning, sat in your pajamas on a web call. It's about getting your hands dirty, understanding the ins and outs, and it comes back to the unknown unknowns. And as soon as you start talking with someone who's been there and done it, then you really actually appreciate that there's a lot more to being a CSO than just having completed the training programs that are there. And I'm not going to go into the relative qualities of those at the moment, but it's about actually knowing how to deliver your expertise, and knowing how to produce a hazard log, knowing how to make that coherent and understandable and legible, how to produce a clinical safety case report, which is understandable if you're going zero, if you're doing the 0129 for the healthcare organisation CSO, so that they're not just drowned in pages upon pages of document without actually really being able to see clearly what are the risks, what are the transferable hazards, what are the recommendations that they need to consider, what are the headlines. And these are not skills that you get just by doing a webinar. Or doing some e-learning. These you actually have to be doing them, and you also need to be doing it with someone you trust and someone that you know can deliver education for you, and also someone that can support you when things go wrong, because that is actually when you learn the most. And there's in medical education, you had at one point the see one, do one, teach one kind of attitude, which was quite scary, to be honest. And
Totally,
it's not like that, is it? It shouldn't be like that. It should be, actually you need to go through those, like, as you start to learn, your confidence increases, but then you get a knock and your confidence goes down. But it's actually when you have a knock and you have someone that you can then learn from, that is when you learn the most, and then your confidence can actually reach a higher level than it was previous, because you have more knowledge behind you. So it's really crucial, I think, and but it's also crucial that the mentors are of a sufficient quality as well. And I think there needs to be a piece of work on that, about how you get to mentorship level, training the trainers, and what qualifications and standards you need to have been to achieve that. Because ultimately, we're all about regulations. That is what being a CSO is about. And if we're not regulating ourselves, then it looks a bit hypocritical, really, doesn't it? To be honest.
No, you're right. You're right. You're right, Tom. And it begs a question. It's just totally hypocritical, isn't it? That sort of
Yeah.
like, the regulators aren't regulated, and sort of, and I know it's, people will argue and say, and there'll be people in the audience that will say, yeah, but we're self-regulated, NHS England and the digital clinical safety team are not the regulators. Then we've mentioned this before, then who are in relation to that? And we know things need to change. And maybe I'll put it out there, certain roles can be advocates for that. It's just been announced last week. We've got a newly appointed CCIO for NHS England, and it's official that Helen Balston is the CNIO in relation to that. Where's the CXIO as well? And I know Leah Parry will probably be going, yeah, Dean, yeah, we need to sort of, but where are they? Where's the other sort of, like, in relation to that at a national level representation? Yeah, I think and from other episodes, I'm not a big fan of C-suite. In relation to that, we need to be practical and we need to get things done. And I think it begs a question as well in relation to, why are we not seeing an amount of clinical risk management, and it needs to be pitched at the right level, in mandatory training?
Exactly.
Why aren't doctors, nurses, physios, anyone within that sort of, OTs, pharmacists, I can't sit here and name everybody, but we know who we are. And why is there not, why is it not in the curriculum? Why is it not there? Because digital health, I'm not just saying clinical risk management, there needs to be modules around, and there may be something happening in the background, but I'm not hearing about it. So that needs to be pushed forward.
And it's, I think there's two prongs to that. So there should be something at an educational level. So when you're completing your medical degree, or your nursing midwifery qualifications, etc., and the GMC could quite easily turn around and add that to the curriculums, if they wanted to, and the medical schools would have to incorporate that. And then I think it should also be part of every NHS staff members statutory and mandatory training. So, and I know people roll their eyes when you hear
Absolutely.
that, not more statutory and mandatory training. But, if we're doing training about, manual handling and the like, then why isn't clinical risk management and digital clinical safety on there? And I think it should be tiered as well. So, you can have the basic clinical risk management awareness for certain staff members, going all the way up to C-suite and top execs who have to do level 3, level 4 awareness, and really you can stagger it as well if you need it, like that. It's a bit like there is with the safeguarding training, which has different levels depending on your responsibilities, and that they have to be completed on an annually or 2-yearly basis. Would be a really good way of making sure people are aware of that kind of thing and aware of clinical risk management, because it's gone past the point where digital technologies are just an adjunct to our practice. If I went into a GP surgery or hospital tomorrow and someone said, you could take away either my stethoscope or my smart card, so I can't even use my stethoscope, or I can't get on any other computers. Which one would you rather have? I'll say I'll definitely take my smart card. I'll leave my stethoscope at the door, and I'd probably leave my whole doctor's bag at the door, if it meant I could get on the computer and work, be able to access the patient notes and prescribe, etc. These things are now integral to our working, and you have training at medical school about how to use a stethoscope. Why isn't there any training about how to use digital systems correctly, spot when they're not working properly, spot when they are creating inefficiencies and hazards within your workflow? I think it's really counterintuitive, and it's setting people up for failure, and it's also creating the situation when people are using, and we'll probably talk about it in a bit, using technologies like ChatGPT and stuff, where they're using it in a bit of a naive fashion because they're not aware of actually the risk associated with it, and how that ties in with the work that we do. And you feel like sometimes you're having the same conversation with the same groups of people, trying to make them more aware of the risks that they're exposing themselves to.
And you've hit the nail on the head there, Tom, haven't you? And talking about sort of, you must have read my mind leading on to Chat GPT. We've spoken about AI previously, not in any sort of depth, but it's out there. Digital technologies, like I said before, they're not going away. They are part of our lives now in relation to us as clinicians. And you're absolutely right. Why we seem to be ignoring the fact that they are there. And it was always a big tester for us at IMS when I worked there. If you were to turn around and say to the scenario, oh, we're switching the system off tomorrow, they'd be like, what? You can't switch the system off. How can you do that? That would bring everything to its knees, etc., etc., etc. However, that awareness isn't there for the greater sort of workforce, or I say, let me sort of retract on that. Not necessarily the awareness isn't there. I think it's the awareness that if it was to be switched off, we take it for granted, don't we? It's just, we just assume it's there and it's just running. Yeah. Which is thankful to sort of IT departments as well and stuff like that, not just the clinicians and the manufacturers. They do an absolutely fantastic job. But coming on to sort of, the AI side of things, and I want to come to a post that you put out the other week, or there was an article that came out, wasn't there, and you posted about it. That for me, it's absolutely shocking. 1 in 5 GPs using ChatGPT to suggest diagnosis and for writing letters. The introduction of AI is just forever increasing within the NHS. We have a duty of care as CSOs to make sure that they're safe, to be deployed. And it's like, how are we prepared to meet this challenge?
Yeah.
And and what can we do in relation to that?
Yeah, so the post I put on LinkedIn, feel free to reach out and follow and connect, obviously on LinkedIn if you want. It was an article from The Guardian saying that 1 in 5 GPs use ChatGPT for suggesting differential diagnoses and treatment plans, and I think it's 25% use it for writing referral letters, which is a, I might have got the percentage slightly wrong off the top of my head, but it's roughly around that level, and I think it's a bit of a well, it's quite eye-opening. And then when I was at Het, I actually met a GP colleague, and I probably had a 10-15 minute discussion with them about this, and they were using.
That's right. I was
they
there.
were
Yeah,
they
yeah.
were using
Chat.
they were using ChatGPT just for this kind of thing, and for writing referral letters. And I think this again goes back to the awareness, which I think we've covered off in sufficient detail. So I won't go through that again. But I think it always goes back to about I think we need an AI strategy. We need a plan as to where we're going with this. And I don't want people to come away from this podcast, if you're still listening, thinking I'm against AI. I'm not. I think it's going to be great. I think there's fantastic opportunities to really revolutionize healthcare, and the NHS is desperately in need of something like this, and this is a big opportunity we have of providing change that we need within the NHS and within healthcare, and making a healthcare system which is more efficient and can deliver better patient outcomes is crucial.
Yeah.
But we have to decide, and this maybe has to be government led or NHS England led, what we want the end goal to look like. And I think that is more than just saying, oh, it'd be great if we can get AI to in as many places as we can do. It is about saying, what do we want GP jobs, primary care, to look like in 10, 15, 20 years' time? What do we want consultants to their job profiles, and nurses, pharmacists to look like in 10, 20 years' time? Where are we trying to go? And how can we then get AI to help with that? And where can we bring that in, and other technologies to get us to that point? Because if we're not careful, we'll end up with a tail wagging the donkey, and we'll have AI, all these AI opportunities, and we'll bring them in, and we will have a situation where we will have accidentally fallen into a new healthcare model, which hasn't been by design, but it's been by accident, because we've brought in all these AI technologies, and we've in a non-strategic kind of way. And the other thing to remember is that actually using new technologies, not just AI, but any new technologies, requires great infrastructure development. So it requires education, but also the infrastructure to go with that. And we have to, and I was on another podcast I listened to, it's a great phrase, to try and avoid the development of an AI aristocracy, which is where the areas or specialities which are already quite digitally advanced, having the capabilities to develop and incorporate AI and new technologies quickly, where compared to other geographical and clinical areas, social care, which aren't as technologically advanced, don't have the resource to do that, get left behind. And we know there's healthcare inequalities. There's inequalities in mental health. If you have a mental health condition, your physical health suffers. There's regional differences in inequalities in healthcare outcomes, which and there's these a
and
revolution, which AI could be, should give us the opportunity to try and address this. And my concern is that if we do this in an unstructured and non-strategic way, it might actually reinforce these inequalities instead of trying to level the playing field. And I'm loath to use the phrase leveling up because I think that's now got negative connotations, hasn't it? But we've got to try and get everyone to an equal footing, and there needs to be greater AI strategy amongst that. And part of that is actually saying these technologies are going to be great. They have the potential to revolutionize healthcare, but almost taking a step back and saying, let's just hang off and decide where we need to go before just rushing headlong and like a kid in a sweet store and picking out everything we can and realizing that we feel a bit sick and we need to go home to lie on the couch.
That's fantastic, Tom. And I can see you're passionate about sort of like the adoption of AI, and you're absolutely right. It's not anyone saying. I think in lots of the conversations I had, it's not everyone saying don't do it, don't
No,
put it
definitely not.
in.
Yeah.
No one's saying that, but it's like doing it. And I'm a big advocate in relation to this whole knowledge gap. Having spoken at Het North back in March, and it's a real worry for me that we're adopting these technologies. We've got regulation which is in its infancy at the moment. We've got AI management system standards, the application of or the validation of AI within the healthcare setting, and the the European AI Act has come in. But again, this has all happened within the last year. This isn't sort of something that's been around for or is established at the moment. And we have health organisations that are rapidly introducing AI. And, I was part privy to that conversation you had at HET. And I think both of us were a bit sort of taken aback by, I think it was the attitude. And I don't think it was, it's people looking at it as in a positive attitude, but that are
And
badly informed. They're sort of like, look at this, and it's creating all of this for me, and it's doing all of this at the touch of a button. But it's like, yeah, it is. But do you realise that the risk in relation to that you could be sort of doing, X, Y, and Z, and they're just oblivious. Some
And
people to that sort of, and that's the scary part
yeah,
of it, is that they're sort of, and then that has a knock-on effect as we go through, or they start speaking to their colleagues, and again, sort of like that awareness sort of raising. But when in this instance, talking about awareness, it's about, and I asked this question when I spoke at Het North, is around, I mentioned some terminology. I just put some phrases out there in relation to AI and supervised and unsupervised learning, and asked the question to the audience: do you know what they mean? And they were like, no. And it's like, well, my question to you is, if you don't understand the principles of supervised and unsupervised learning and what the AI is actually doing, how can you risk assess it? How can you deploy it
yeah,
into your organization if you don't know what it's actually doing, the fundamentals? And I think it's really scary in that respect, that we're now we're now in a world, aren't we, where, you know, again, AI is here to stay. It's not going away. But are we putting the right message across in relation to how it's been adopted? And it comes back to what we've mentioned before around top management have a responsibility to make sure that that's done in the proper fashion, and that it's risk assessed.
yeah.
In,
And I
in terms
think,
of,
there's a couple of things. There's one question I want to ask you, which is something it was mentioned many times on that LinkedIn post and also in conversations I had, and I'll come back to that in a minute. But the kind of the way I look at it, my concern is that whilst the regulations are playing catch up, we're in this position where if we're not careful, we'll let bad actors, bad technologies come into the healthcare market, which are actually going to reduce confidence in AI. And another conversation I have is that the media are waiting for the next controversy, the next patient safety incident, and if it can associate with it AI, it's going to be all over the news headlines. You're going to be front page of all the tabloids, and they are waiting for that kind of thing, and that kind of incident will knock back the progress of our industry and knock back the progress of AI and the confidence that not only patients have of it, but our clinicians, our colleagues have in it, and will set us back. So, it is incumbent on the developers as well, if they are developing a top quality product, and there are loads of them about, and they are responsible, again, loads of them about, to really embrace the standards, not try and avoid them, and to really embrace, if they're going to be a medical device, and embrace software as a medical device, embrace AI management systems and all the ISO standards, to try and elevate the standard and elevate the minimum standard that these products have when they go into the NHS, so that you stand out from the crowd, but also the ones that are produced on a wing and a prayer don't get in the front door, don't get in the back door, and don't bring the quality and the confidence of our industry down. And the question I want to ask you, Dean, is I often get asked and commented on, my comment was like, well, you're just kind of like, it's almost like Project Fear kind of thing. You're, everyone said the same thing about Google and AI, in respect to AI. So, Dr. Google, in the noughties, people, it's the same thing, isn't it? Google gives you an answer, AI gives you an answer, and I'm trying to argue that there's this big difference between Google and AI, which people don't seem to understand. Well, not don't seem to understand. Sorry, don't seem to agree with. And I would appreciate what your views on that are.
No, absolutely. And I was chatting to Brett, the other Brett Marshall, one of our regulatory affairs sort of consultants, and talking about AI. Brett's big on AI and he's taken numerous courses and has a very firm footing in that space. And Brett, it was really interesting actually, Brett saying, he said, Dean, people need to think of, so AI is a big data processor. That's what it is. However, what it is doing, it's the complexities of AI that make it different from anything else, and in what it's actually doing and how it's delivering the information. And this is where we need to bring in those principles around transparency, accountability. You need explainability as well. These are key in the deployment and in the introduction of AI. Anyone that's talking about, oh, well, Google did it however long ago and etc. stuff like that. So yeah, but we've got to take it into account. This is healthcare we're talking about. Okay. At the moment, I'm a big advocate. There's always needs to be a human in the loop.
Yeah.
We're not ready. We're not going to be ready for 4 or 5 years or more in relation to that, because we don't have the confidence, and the AI probably doesn't have the confidence in itself in relation to what it's trying to achieve. And from the manufacturer side of things, they need to adopt a policy of transparency and explainability. If you cannot explain your AI and what it can do, then you need to go back to the drawing board. Yeah. Don't get me wrong. Yes, there's be people on here and saying, yeah, but what about the black box? And what about, sort of those areas? Yes, we understand that. There's, that unsupervised learning. But however, you have trained that. There is always the supervised element of AI. yeah, get that right, and make sure that's evidence based and it's as safe as possible. Then it makes things a lot easier when we're looking at what we're dealing with within the black box. And it's health organisations' responsibility as well to demand that from manufacturers, and to have a level of understanding themselves in relation to that. So all the way along, this is what needs to happen, because otherwise, we, like you say, we're going to be we're going to be taken over by people, but by AI systems that are just sort of are just going to chug along. And we're unaware of the risk that's out there. Tom,
And
we're going to have to stop there. It's been absolutely fantastic talking to you. I know we could go on for another couple of hours if we had the time.
Yeah.
And, there will be the opportunity to sort of, to get you back on, so we can sort of, we can continue these conversations. What I do with all of my guests is, at the end, is ask you a final question about if there is one takeaway that you could sort of give to the audience in relation to digital health, clinical risk management. And I know it's putting you on the spot, but what would that be, Tom?
So I think it's going back to what I mentioned earlier, which is implementation and innovation should go hand in hand with equal time, energy, and effort, and that we shouldn't let patient safety be sacrificed for innovation. We should prioritize both equally, really. That's my take-home message. That's what I try and encourage all developers and healthcare organizations to consider, and that if this is done correctly, we can really create an efficient and safe future for the NHS, which can try and make our jobs as clinicians more enjoyable and prevent people leaving and prevent burnout, which is something which is not pleasant and not an enjoyable place to be.
And Tom, thank you ever so much for taking part in episode 10 of The Only Way is Ethics. It's been an absolute pleasure to have you on board. And to the audience out there, you can find us on Spotify and YouTube. So please, thank you for listening. We look forward to episode 11.